Tasks of the lecture are actuality, history and stages of studies about hernias, definition of hernia, weak place of abdominal wall, classification of hernia, modern conception of pathogenesis of external hernias, main principles of technical operations in external hernias. Do you hear me? It's all right?
Yes, sir.
Yes, sir.
Great, great. Actuality. Earlier, yearly, in the world, 20 millions of operations in hernias are carried out. That composes from 10 to 15% of all operative interventions. Each third, fourth, fifth inhabitant of the earth is a potential carrier of hernia. Peak of morbidity is observed in preschool age people older 50 years. In Russia, yearly about 260,000 of operations are carried out. Recurrence of disease arising each 8/10 of patient, average 10-15 of patients. History of surgery of abdominal hernias. Condon and Nihus said that the history of hernia is history of surgery. At this picture you may see Claude Galen. The first time introduced term hernia. It was many years ago, as you may see. Yes, Claude Galen. First definition gives. Here you may see Cornelius Sales. Cornelius Sales, first century of our days. Yes, Cornelius Sales introduced classical determination of hernias as protrusion viscera through acquired and congenital hills, called them hernia. He suggested method of transillumination of scrotum for differential diagnostic. He opened sac, cut strangulated ring, and organ set into abdominal cavity. So he did first herniatomy operation. Yes. Gilliador, 4th century, recommended to use bandages in small hernias in children, carried out operations only in adult in big hernias. It's a bandages you may see of that time. Abdominal hernias history. After the opening of anesthesia, asepsis, antisepsis, of course, it did seriously progress. Yes. In 19th, 20th century, scientific approach in study different of aspects of herniology. Cooper, Hesselbach, Lagengup, Bolotsky, Bobrov, and others. The outcome of hernia surgery is very surgeon department dependent. And Astley Cook's quite statement of 1804 is still pertinent and appropriate introduction to this lecture. No disease of the human body belonging to the province of surgeons requires in its treatment a greater combination of accurate anatomical knowledge with surgical skill than hernia in all its varieties. First plastic operation in inguinal hernia was made in 1885 by Championnier in France. In Russia, a similar operation Bobrov carried out in 1892 year. Bassini, Postemsky, Spasokokotski laid basis of modern herniotomy. Definition of hernia. A hernia is defined as a protrusion of a viscera with parietal peritoneum, it's very important, through an opening, natural or artificial, in the musculoponeurotic layers of the abdominal walls under the skin. Clinically, the important point of the definition is the protrusion, because without protrusion viscus, a diagnosis of hernia is essentially impossible. Anatomically, the important features of the hernia are the hernial ring and hernial sac. Classical elements of hernia. Red indicator show that the hernial ring or orifice, it's a weak place for which hernia protrudes. Hernial sac, it's a green indicator showed. Hernial sac, parietal peritoneum. And hernial contained, blue indicator showed. Here it's a loop of small intestine. Hernial ring, defect in the innermost aponeurotic layer of the abdomen, or weak place, we can say. Hernial sac, outpouch of peritoneum, protrusion of parietal peritoneum. The neck of the hernial sac corresponds to the hernial orifice. The size of the hernia is determined by the dimension of the neck and the wall of the sac. A hernia is external if the sac protruded completely through the abdominal wall. A hernia is interparietal if the sac is contained within the abdominal wall. And a hernia is internal if the sac is within the visceral cavity. The hernia is reducible, then the protruded viscus can be returned to the abdomen. The hernia is irreducible, then the protruded viscus cannot be returned to the abdomen. And strangulated hernia is one in which the vascularity of the protruded viscus is compromised, usually at the neck. Strangulation is most likely to occur in hernias that have small orifice and relatively voluminous sacs. Weak places are, by Krimov definition, parts of the abdominal wall devoid of muscles upon neurosis, having muscular and aponeurotic slits, through which the vessels, nerves, anatomical structures may pass. The weak places are umbilical ring, slits in linea alba, inguinal canal, fennel canal, semilunar line of Spigelian, arcuate line of Douglas, inferior lumbar triangle of Petit, superior lumbar triangle of Lesgeld-Grünfeld, and the obturator and sciatic foramens of the pelvis and perineum, and maybe postoperative or post-traumatic weak places. Scar, it's a new weak place. In this picture you may see classification of hernias by anatomical position. Linea alba or epigastric hernia, yes, umbilical hernia, inguinal hernia, this one, femoral hernia, postoperative hernia, incisional hernia, yes, here you may see scar after some operation, semilunar hernia, along Spigelian line, gastric umbilical again. Yes, as you may see, the inguinal hernia situated above inguinal ligament, and femoral hernia lies below inguinal ligament. Rare types of hernias, it's hernias, lumbar hernias. This one through triangle petit or T triangle. This one inferior lumbar triangle, and this one for superior lumbar triangle. It's a Lesgov-Grunfeld triangle. Lesgov-Grunfeld triangle. It's a rare types. Classification of hernia, anatomical classification. It's external hernias maybe and internal. External, inguinal, femoral, umbilical, hernia of linea alba, hernia of semilunar line of Spigelian and arcuate line of Douglas, hernia of xiphoid process, lumbar, hernias inferior lumbar triangle of Petit, superior lumbar triangle of Lesgov-Grunfeld, hernia of pelvic floor, the obturator and sciatic foramens of the pelvis and perineum, and postoperative post-traumatic hernias. And internal hernias, frequently it's a diaphragmatic hernias. Here, internal hernias demonstrates, you may see, diaphragm, esophagus, stomach, and through esophageal foramen, part of stomach, fundus at this situation may protrude outside from the abdominal cavity and entering thoracic cavity. Part of fundus or all fundus of stomach, yes, at this picture you may see all stomach produced in thoracic cavity from abdominal. Yes, it's all internal hernias. Hernias of the esophageal foramen of the diaphragm. Next classification. Hernia may be congenital and acquired. Hernia may be reducible and irreducible. Uncomplicated and complicated. And acquired hernia may be traumatic and dystrophic. Deep diagnosis. Hernia with eventration and prolapsus. Eventration. It's a protrusion on the organs of the abdominal cavity through suddenly developing or congenital defects of abdominal wall without covering by peritoneum outside. Eventration may be congenital, traumatic, and postoperative. Prolapsus. It's a protrusion of the organs or part of them through natural foramen of its cavity without covering by peritoneum. Prolapsus of the rectum through anus, yes. Prolapsus of the vagina and uterus through vagina. Cavity of the abdomen is limited by superiorly diaphragm, anterolateral by muscles of prelum or press of abdomen, posteriorly by vertebral column and muscles of lumbar region, and inferior by pelvic inlet. The abdominal cavity, it's the biggest cavity of our body. Так, abdominal wall demonstrates with this picture. Muscles of abdominal wall superficial and middle layers here present. And in this picture, middle layer. So which muscles we have? Lateral group and medial group. Medial, it's rectus muscle, left and right. And laterally, we have three layers of muscles. Yes, external oblique abdominis, this one internal oblique abdominis muscle, and beneath it situated transverse abdominis muscle. Clinical term for parts ligament. Muscles of the abdominal wall abdominis deep layers. It's here demonstrates transverse abdominis muscle. Transverse abdominis muscle. Well, and then aponeurotic layers of each lateral muscles. They cover the rectus muscles and arise the sheath for rectus muscles. Along lateral side of rectus muscle, we have aponeurotic plates, a Spigelian line here, one of weak places. Spigelian line. Function of wall. Supporting for organs, external respiration, regulation of blood circulation, regulation of intrathoracic and intra-abdominal pressure, motor activity of gastrointestinal tract, movement of tongue, shoulder, girdle, and pelvis. Walls of the abdomen endure big physical efforts. It is 20 minutes now, and students calm and calm. Interesting. Elastic basis of the anterolateral abdominal wall is composed by 3 pairs of leg muscles, lateral group, and pair of rectus abdominis muscle. Here you may see how the intra-abdominal pressure pressed on the muscles. Yes, maximum is in center. Phenomenon of intra-abdominal pressure is determined by interaction of effort of muscles of abdominal wall, elasticity of flow by blood of parenchymal organs of abdominal cavity, elasticity of peristaltic hollow organs of abdominal cavity, value of pressure 15 till 230 millimeters mercury column. Physiological importance of intra-abdominal pressure. Intra-abdominal pressure provides fixation of abdominal organs in defined position. It is known, for example, that in weakening of muscular tension with ages, enteroptosis, partial or total is developed. Intra-abdominal pressure promotes to maintenance of normal function of abdominal organs, makes more active blood and lymph circulation in the abdominal cavity. Positive role of intra-abdominal pressure is provided by dynamical balance of value of muscular tension and intra-abdominal pressure. In prolonged increase of pressure and decreased mechanical durability of the abdominal wall will occur formation of hernia. Hernias of the abdominal wall occur only in areas where aponeurosis and fascia are devoid of the protecting support of striated muscle. Factors of hernia formation. Productive. It's increase of intra-abdominal pressure, work, weeping, crying, delivery, constipation, cough, heredity, and predisposed. Weak place of the abdominal wall, everyone here. Peculiarities of constitution, type, sexual and age differences. Changes in the abdominal wall with ages. Connecting with pregnancy. Unfavorable conditions of work and mode. And pathologic states.
What does it mean by sexual? Sexual like intercourse?
No, it means that, for example, inguinal hernias frequently has males and opposite femoral hernias frequently has females because different structure of pelvis. Yes?
Yes.
Weak places may be divided in canals, it's inguinal and femoral canal, foramina and slits in linea alba, and slits and aponeurosis of external oblique, internal oblique, and transverse abdominal muscle. Inguinal hernia takes 3–4% of population carried of hernia. In USA, yearly 700,000 operations are carried out in inguinal hernias. The groin inguinal is one of the natural weak areas in the abdominal wall and is most common site for abdominal herniation. Well, at this picture demonstrates, yes, the boy with inguinal scrotal hernia, yes, then inguinal hernia enters in scrotum. So we may say that it's what? Which inguinal hernia? It's an oblique inguinal hernia, yes. Then, at this situation, patient with inguinal scrotal hernia in standing position. You may see. As I see, this one has from both sides. Yes. Here and here. Giant inguinal hernia look so big. Till knees. Yes, the scrotum downward till knee. Why this patient so many years sitting at home, I don't know. The canals of the abdominal wall are the most weak places of the abdominal wall. No, why? First, they are constant. Yes, everyone has canals, inguinal canals. Presence into canals of large anatomical structures. And it's prepared through the effect of the abdominal wall for formation of hernia. At this picture, what we can see it's a boy, yes, it's a spermatic cord follows, which exit from the inguinal canal. Inguinal hernias pass through inguinal canal and compose 63–90% of all hernias of abdomen. It takes first place. Both sexes of all ages are FSC. At least. But men are 25 times more likely to have an inguinal hernia than women. The estimated incidence of inguinal hernias in men is 3%, thus making hernias a major economic problem. Inguinal hernia in women, a rare situation, but here we may see protrusion through inguinal canal. Inguinal canal structure. At this picture you may see the opening of inguinal canal, yes, anterior wall on forceps. It's aponeurosis of external oblique muscle. Yeah. And this superiorly it's a transverse muscle. Here you may see the spermatic cord, superficial, number 9, yes, it's a superficial inguinal ring. No, at this area, situated deep inguinal ring. It's abdominal wall from inside. Between them we have fossa, supravesical fossa, medial inguinal fossa, and lateral inguinal fossa. For lateral follows spermatic cord. Same for lateral fossa may enter and inguinal hernia. It will be oblique inguinal hernia. Remedial inguinal fossa may produce direct inguinal hernia. Direct inguinal hernia. Oblique inguinal hernia will go along spermatic cord, and with spermatic cord it may enter in scrotum. Direct inguinal hernia cannot enter in scrotum. Inguinal canal deep rings, again here demonstrates bladder, folds, deep inguinal ring. It's the same as a lateral inguinal fossa. If hernia produced here, we call it deep inguinal ring now. Inguinal canal in pathology. Under 34 years, superficial inguinal rings increase, especially in men older 60 years. Size, especially in size of deep ring with age increase. 15–17% of high inguinal interval is absorbed, and deep ring is not covered by muscles. In 26% is partially covered, and in 57% inferior margin of muscle completely covers deep ring. At this picture, you may see the examination, yes, manual examination, comparative palpation of spermatic cord. Here palpation of superficial inguinal ring when we take our second finger and indices and put it in area, same as here demonstrates superficial ring palpation by fifth finger, yes, here by second, here by fifth. Well, doctor puts his finger in area of superficial inguinal ring and ask patient to have cough. Then patient have cough, yes, few times. Intra-abdominal pressure increase at this moment, and doctor by his finger may feel the protrusion in cough moment. Yes, he may feel the protrusion of hernia. Inguinal interval, boys and girls. What is it? Inguinal interval, it's a distance between inferior and superior walls of inguinal canal. Inferior wall of inguinal canal, it's a inguinal ligament. Here. Superior wall, it's a transverse muscle. In hernia, superior wall, it's a transverse muscle, and free margin of the internal oblique muscle. So this distance, you may see these two different pictures. Yes, here short distance we have between inferior and superior wall, and here distance is so big. Of course, the patient which has big distance, inguinal interval, has higher risk to have inguinal hernia. Yes, if interval is short, risk is lower. In 32% of men and 14% of women, inferior fibers of internal oblique muscle pass horizontally above spermatic cord, and arch is only formed by inferior margin of transverse abdominal muscle, or both muscles pass horizontally. In triangle shaped of inguinal interval, the shooter mechanism is absent. Yes, interval may have few shapes, triangular shape, yes, as here, triangular shape. It may be oval, as here, and it may be round, And if it's triangular shape, the shooter mechanism is absent. Shooter mechanism demonstrates here, for example, this well, shooter mechanism of the transverse muscle, transverse fibers of transverse muscle, which closed the interval. Transverse fascia in 33% is reinforced by muscular and tendinous fibers. Transverse fascia is reinforced by tendinous fibers from internal oblique, transverse, and rectus abdominis muscles. The medial part of transverse fascia is reinforced by formation of the conjoint tendon, inguinal falx, or Henle's ligament. Here, the merging of the pubic attachments of the internal oblique and transverse abdominal aponeurosis into a content ligament is the lateral part of the transverse fascia is reinforced. Schematic mechanism of deep breathing and movement in all and split-shaped muscular structures combat the action mechanism. The internal oblique abdominal muscle covers the deep breathing and compensation mechanisms. The muscular contraction of the scapula in the lower ligament and complements the suture of the internal abdominal muscle by pulling the cord at the beginning, laterally and superiorly. Inguinal shortness is a proposal of population. Maybe in the level of congenital and acquired. The second in the level was slowly toward the end, ultimately to the sport. And the second direction protrudes directly forward forward, and maybe slightly so in the level maybe congenital and acquired. Parallel is always only acquired. Congenital inheritance. But this usually has also tested processogenesis is not processogenesis is social and hybridization for processogenesis is not that and it's upgraded on 60 parts shorter and systems from for normally in fetal period and then it goes downward. It's called the descending our test is called tunica vaginalis. Normally, the tunica vaginalis cavity and peritoneal cavity, between them should be obliteration. It's a normal. But if it's not obliterated, they have community. In this situation, patient may have congenital Sometimes obliteration goes partially. If it's partially, patient may have different problems, hydrocephalus or cysts. Like 1 moment, please wait. let's continue. Yes. So, and if it's partially obliterated, it's maybe here formation or spermatic cord, maybe formation of the different seeds. Congenital indirect inguinal hernia. This situation possible to have, yes, then community between clinical vaginalis and peritoneal cavity is present. Yes, and this picture demonstrates hernia. Protrudes through lateral inguinal fossa or enters deep inguinal ring. Hernial sac is formed by process vaginalis and is covered by all three facial coverings of the spermatic cord. So hernia was situated under the sheets of spermatic cord. Then transversus enter inguinal canal, exits through the superficial inguinal ring, and commonly enters the scrotum. May enter scrotum. Acquired indirect inguinal hernia demonstrates here it's a spermatic cord. Sheets of spermatic cord will open on forceps, and we may see the hernia. This blue color, it's a peritoneum, so hernial sac, yes. And inside we may see this white color, it's a intestine, loop of intestine. It demonstrates mechanism protrusion in sagittal plane, protrusion for replaced entrance in canal, then through superficial inguinal ring, exit in subcutaneous tissue, and then enters into the scrotum. Now it's inguinal scrotal hernia. Quite indirect inguinal hernia. Here demonstrates different patients. It's a baby, yes. It's adult patients with big inguinal hernias, inguinal scrotal hernias, yes. Quite indirect inguinal hernia. It's produced through lateral inguinal fossa or enters deep inguinal ring. Transversus enter inguinal canal anterolaterally to spermatic cord. Exits for the superficial inguinal ring and commonly enters the scrotum. So, what is the difference, main difference, boys and girls, in congenital and acquired inguinal hernia? If it's congenital inguinal hernia, the hernial sac, it's a tunica vaginalis and testis. Testis part of hernial sac. If it's acquired indirect inguinal hernia, the hernial sac, it's just parietal peritoneum layer, not tunica vaginalis. Yes, it's a main direct inguinal hernia. This is a picture. Here's spermatic cord, lateral hernial sac, the hernial sac, and inside loop of intestine units, hernial container. So, direct inguinal hernia protrudes through medial inguinal fossa, indirect through lateral, direct through medial inguinal fossa. Passes through inguinal interval, lies outside the spermatic cord, medially to it. Doesn't traverse the entire inguinal canal, usually only its most medial part, lower end, and adjacent to the superficial inguinal ring. Almost never enters the scrotum. Clinically distinguished and an indirect form and direct inguinal hernia is often impossible. So before operation, we cannot say it's direct or indirect. Only intra-operation. Final diagnosis. This organ is which covers mesoperitoneum. It's a loop of intestine. Blue line is a parietal peritoneum. Here, 45 with place for which loop of intestine produced through abdominal wall. So it's produced parietal peritoneum. And then parietal peritoneum goes outside. It pull the wall of whole organ. In this situation, it's a urinary bladder wall. Why it goes with it? Because it slide in short. Yes. Why it may slide? Because it lies on fat tissue. That's why wall may slide and enter as a part of hernial sac. It goes through the weak place. So hernial sac here, it's a parietal peritoneum and wall of urinary bladder. This condition may be present both in indirect and direct inguinal hernia. Some or all of the hernial contents lies outside the peritoneal sac. A part of the colon, which is divided of mesentery, the cecum and ascending colon on the right, the pelvic and descending colon on the left side, or a portion of the bladder, urinary bladder, is found to be incorporated in the posterior wall of the sac. Main stages of herniatomy. First, it's a removal of the sac, hernial sac, and second stage, it's a reconstructive procedure, repair of defect with place, or prevent recurrent hernia. Removal of the sac. Application of hydropreparation and gauze dissection for release of sac from surrounding tissue up to its neck. Sac is opened, that is fundus. Exploration of the sac. The neck of sac is freed from the margins of ring and ligated by transfixion or by poor stream suture at the highest position, possible point, and it's cut off, and then hemostasis. It's the first stage, removal of the sac. Affiliations in inguinal hernias. They are determined by degree of destruction of posterior wall of inguinal canal and degree of destruction of deep inguinal ring. Autoplastic methods we have strengthening of anterior wall of inguinal canal by common tissues. It's a Gerard autoplastic method, Martinov and Rukov. Strengthening of posterior wall of inguinal canal by Janov, Scholdice, methods. And endoprosthetic methods by the only mesh, synthetic mesh prosthesis is 3-tension plastic surgery of inguinal hernias. For example, Liechtenstein method. Operations in inguinal hernias, classical herniaplasty. Autoplastic methods, strengthening of anterior wall of inguinal canal and strengthening of posterior wall of inguinal canal. So if it's indirect inguinal hernia, we should strengthen or protect the anterior wall of inguinal canal. If it's direct inguinal hernia, we should protect or strengthen posterior wall of inguinal canal. Tension is the principal cause of failure of all the hernioplasties that close the walls and wings by aponeurotic approximation. This picture demonstrates the different types of operation, sutures, in classes, in practical classes with teacher you will about every method which demonstrates here, you will by shoulders, operation of shoulders. What is advantages of multi-layer plastic reconstruction are evaluated. In long-term period up to 3 years, recurrence they are seen in 0.5 to 1%. This is 10 times less than in plastic surgeries of anterior wall of inguinal canal. Multi-layer plastic reconstruction is particularly indicated for patients over 40 years with long unmated weak tendinic structures, severe destruction of the posterior wall. This surgery is universal, can be performed in elective and urgent situation. Recurrent hernia. At this situation you may see the scar. Well, this patient had a hernia, then had operation about hernia, and now at some place, patient has again protrusion. It's a recurrent hernia called recurrent hernia. And for hernioplasty here, for example, demonstrates the mesh, special synthetic material. Yes, it has two layers here, for example. It's a special umbilical herniatomy. One layer will go under the aponeurosis and another layer will lie on aponeurosis. So we protect and we put it and sublay and onlay. And the prosthesis by the onlay mesh, synthetic mesh prosthesis. Synthetic mesh prosthesis currently play a major role in the management of hernias of the groin. In general, prosthesis repairs are received for patients at high risk for recurrence after a classical hernioplasty. The most prominent example is recurrent hernias, but their routing used in primary hernia repair is increasingly common. Synthetic mesh prostheses are used to reinforce the classical repair and to replace the transversalis fascia. Here you will see it's inguinal hernia again, yes. On the folder here situated the and this is the mesh. This blue point is the sutures. The mesh of the bottom of the image, and the order is fixed to and ultimate remains on each side, and this carried upwards beyond the neck of the sac. The bowel is then elevated. Its peritoneal surface is covered by stitching again the peritoneal fringes on each side. The bowel, which has been freed from the sac and reperitonized, is replaced within the abdominal cavity. The neck of the sac is closed by a porcine suture, and the rest of the sac cut away. Femoral shortness. Next type of shortness is the femoral shortness. Femoral shortness protrude full femoral canal. Takes 5 to 8% from all shortness. They occur occasionally in women, especially older women. Why it's happen? Because wider pelvis. If pelvis wider, deep ring of femoral canal is wider, more than 1.8 centimeters. In projection of ring, muscles of nervosus ligaments are absent. I hope you remember from previous semester, yes? And we talked about lacunas, lacuna muscular, lacuna vasorum. And in lacuna vasorum medial side, we have deep femoral ring. Deep femoral. Here it's separated medially from femoral vein, yes, and below inguinal ligament. If looking from type position, here muscular lacuna, here vascular lacuna. It's an artery, it's a vein, and medially from vein, preface. Normally, actually, here situated the lymph node, Rosenmüller-Piragoff lymph node, and surrounded loose connective tissue. But from abdominal wall area, here we have deep femoral ring, which has projection at this place. Femoral shortness demonstrates, as you may see, it's below inguinal ligament, it's inguinal see, yes, and protrusion situated below. It means that it's femoral hernia. Hernial sac, opening for hernial sac, yes, it's a inguinal ligament. It's a femoral vein here, middle femoral hernia. So the sac descends through the femoral ligament to femoral canal and turns forward through the saphenous opening, the cribulum form fascia, which covers the opening, being thinned out in front. Almost always it's reduced mass about the size of a walnut at the nasal basis of scarpus femoral triangle. The femoral hernia appears irreducible, even for the sac may be empty because fat and lymph nodes from the femoral canal surround the sac. Solitary enlarged lymph node or a synovial cyst may mimic a femoral hernia exactly. The infrequent reducible femoral hernia may be confused with a saphenous mass. Operation in femoral metastasis and inguinal metastasis that compartment. This district is illustrated in functional processes, bulimia, maybe vertical incision, or little oblique incision. Strangulated hernia. Strangulated hernia takes 58% of inguinal hernias. A strangulated hernia is one in which the vascularity of the protruded discus is compromised, usually at the neck. Why neck? Because it's a narrowest place of hernial sac. Neck situated at the area of oriflamme, yes, and if muscles constricts, maybe strangulation. The contents of the sac are constricted at hernial level. In these situations, urgent operation is indicated. Urgent operation. Yes, in Russia, for example, if you could diagnose this strangulated hernia, you have 2 hours to prepare your patient and start to do operation. And this demonstrates different situations, different types of strangulation. Yes, it's so-called retrograde strangulation. Then in hernial sac you see 2 normal loops, but third loop, which enters in abdomen, situated in abdominal cavity, is strangulated and necrosis. In this situation, you may see that hernial content is a wall, part of wall of intestine, not loop, yes, just wall of intestine. And if it's strangulated, it's central strangulation called. Its area may be perforation, yes, perforation of the wall and contain of intestine immediately enters in the peritoneal cavity and patient will have peritonitis. Operation